All right, folks, we're going to go ahead and get started. My name is Dwayne Quasey Wright. I am an assistant professor of higher education administration and the director of diversity, equity, and inclusion initiatives at the Graduate School for Education and Human Development, which is part of the George Washington University. And I would like to welcome you to our World AIDS Day event featuring Dr. Jonathon Rendina. Folks, I was born in 1988. I was born at a different place than when I sit, in a different country, but I was born during a plague. It was a plague that was devastating to communities that I now belong to, devastating to the LGBT community, but also devastating to Black and Brown communities, devastating to immigrant communities. And that plague eventually was given a name, and it was the HIV/AIDS crisis. And in commemoration of all those that we have lost since that time, of all those that we continue to lose, we celebrate World AIDS Day throughout the globe every December 1st. And in commemoration of that event, in commemoration of the tragedies that we have lived through, but also of the perseverance and survival of the many, many Americans of all races, colors, creeds, socioeconomic status, sexual orientations, genders, etc., the Graduate School for Education and Human Development has decided to come together today to share with you an update on the HIV/AIDS crisis, and to present to you an expert, a member of our community, to talk to you about that crisis. And with that said, I am honored and indeed privileged to present to you the speaker for this year's 2022 World AIDS Day event, and that is Dr. Jonathon Rendina. I will read his full bio. He asked me not to, but it's such illustrious, I cannot resist. I will say before that, the one part of his bio that you will not hear is Jonathon and I both graduated at different times from Happy Valley and Penn State. So we are, to start it off. Dr. Jonathon Rendina is an associate professor of epidemiology in the Milken Institute School of Public Health at the George Washington University, and jointly appointed as the Senior Director of Research at the Whitman Walker Institute. And for those of you who don't know, that's right here in DC. He holds a PhD in social psychology and an MPH, Master of Public Health, and epidemiology and biostatistics. Dr. Rendina has received several NHI funded grants as a principal investigator that broadly focuses on multi-level investigations of intersectional stigma and discrimination and their impact on health outcomes for sexual and gender minorities and people living with HIV. In his dual role at GW and Whitman Walker, he oversees the collaborative research between both organizations, including representing Whitman Walker on the executive committee for the District of Columbia Center for AIDS Research. That's known as the DCCFAR, for those that might not know. He has also received a Psychology and AIDS Emerging Leader Award from the APA, that's the American Psychology Association's Committee on Psychology and AIDS in 2018, and was the World AIDS Day Commissioner Special Recognition Award for LGBT health from the New York State Department of Health in 2020. He has also been a fellow of the NIH-funded HIV Drug and Abuse Prevention Research Ethics Training Institute for Fordham University. GW, please show your love for Dr. Jonathon Rendina. Jonathon, how are you?
Hey, Dwayne, I'm doing well, thanks. How are you?
I'm doing well. I'm doing well. I must say thank you for joining us on what I'm sure has been and will be a busy day for you. You know, this is the day where many people who may not be in tuned to the crisis and several crises and intersections of crises that you study and come in. So thank you for sharing this hour or so with us. We really do appreciate it. We are recording up until the Q&A, but I'm just going to dive right into it. And I'm really interested about you, just reading your bio and understanding the work you've done so much. It was intriguing and also fascinating. Before we get into the sort of the nitty gritty, can you tell us a little bit about yourself, your background, and how you personally came to do this work? And, you know, what does it mean for you?
Yeah, of course. And thank you so much for having me. It's a pleasure to be here. Um, so I would say that in high school as an adolescent was a little unsure of what my calling was. And I took an AP psychology course in my senior year of high school that sort of clicked and helped me to understand my interest in understanding the human experience. And then I was fortunate enough, as you've already mentioned, to go to Penn State. And some of my first classes that I took were sociology, psychology, and human sexuality classes that really solidified my interest in those areas of study. I then had the privilege of working in a research lab starting in my sophomore year that was focused on the mental health experiences of LGBTQ youth here in New York City. And that really also then solidified my interests in research and the ways that research can be used to create social change and work towards health equity. And HIV became one of the areas in which I was most interested as a result of its particularly significant impact on LGBTQ communities and communities of color, and the really interesting and important ways that stigma really both results from, but also creates inequities within the communities that heavily impacted by HIV. So I went on to graduate school to pursue my PhD in social psychology to really learn how to better study the experience of stigma and discrimination. And after many series of different research experiences, landed here in DC back about a year and a half, 2 years ago, where I started my new position at GW and the Whitman Walker Institute.
No, thank you. Thank you. Fascinating, fascinating. So folks, Jonathan and I are going to talk for about 20, 30 minutes, hit some highlights. We are recording up until the Q&A, but this is not meant to be a talk to, this is meant to be a talk with. So please feel free to engage in the chat. At the end of our conversation, we will get to questions. You'll be able to ask questions either via the chat or by unmuting and showing your face, not showing your face, and seeing your lovely faces, or just hearing your voice. But please do engage, folks. We know that many of you are coming to learn about the crisis. Many of you already know a lot about it and have specific questions, maybe about specific communities, or want to share about the communities and the initiatives that you're doing here, either in DC or, quite frankly, around the country and around the world. We welcome all that. So I do encourage you to please use the chat. And as soon as we're done, we will engage with you. Again, not talking at you. So Jonathan, it's so interesting, not only your background, I am fascinated by your work, but I'm also honored that you have lent yourself and your, quite frankly, brilliant research to the community here, not only in DC, but in GW. Can you talk first a little bit about what Whitman Walker is? I think that, even though we at GW are in DC, we tend sometimes to exist and almost, as a part of DC and apart from DC at the same time. What is Whitman Walker? How is that important to the DC community, particularly the LGBT community? And how did the partnership between Whitman Walker and Milliken come about?
Sure. So Whitman Walker was originally founded under a different name almost 50 years ago. We'll be celebrating 50 years of service in 2023, and was initially focused on sexual health, particularly for gay men, and STIs that the normal run of STIs that existed before HIV. This was, before the HIV epidemic had started. And then as the HIV epidemic started, it became an AIDS service organization. It took on the name of Whitman Walker and has expanded over time to the position that it's in now. It is a federally qualified health center. Whitman Walker Health is a federally qualified health center. And we reorganized in around 2018 to form a couple of different business entities that work in partnership with one another. And so the Whitman Walker Institute is one of those entities that is an affiliate of Whitman Walker Health, which is our federally qualified health center. And the goal of the Whitman Walker Institute is to accelerate the research, policy, and education arms of Whitman Walker to really give those focus. So we have Those are our three main departments within the Institute: research, policy, and education. In research, we focus on both clinical trials involving the community in clinical trials for life-saving treatments focused on HIV, as well as starting to expand into other areas of health inequities. And we also do a lot of applied and public health research in partnership both with our own internal researchers at Whitman Walker, as well as researchers around the DC area and as well as around the country who come to partner with us on their various research studies. We also have a policy and advocacy department, and they work on policy related issues locally as well as federally, given our location here in DC, and then an education department that focuses on trainings. One of our specialties is LGBTQ cultural competency training. DC became a location that requires LGBTQ focused cultural competency training for medical providers recently. And so that is one of the things that our education department focuses on, is giving out those trainings for continuing education requirements for medical providers. In terms of the partnership between GW and Whitman Walker, I can't say exactly, pinpoint the exact time that it started. We have had lots of GW-based researchers who have worked in partnership with Whitman Walker for a very long time on their research studies. But I would say the formal partnership started probably around 2016 or 2017, when the DC Center for AIDS Research, or the DC CFAR, as you previously mentioned, invited Whitman Walker to become a member institution. So the DC CFARs are a network of NIH-funded centers across the country, and they are designed to support HIV-related research at HIV-focused institutions across the country. And so the DC CFAR includes 8 different member institutions. Actually, I believe we just took on our 9th member institution. But Whitman Walker joining the DC CFAR was really monumental. It was the result of amazing researchers at GW recognizing the importance of community-based research, that research can be done outside of academia. And so it was the first time that a non-academic research organization became a member of a CFAR. And so that was, I would say, the start of the relationship between GW and Whitman Walker, and that has grown into several other really exciting partnerships. A couple of years ago, GW and Whitman Walker were jointly awarded the DC Clinical Trials Unit, which is an HIV prevention and treatment focused network that conducts clinical trials for HIV prevention and treatment drugs, as well as other interventions. And so we are partners in that clinical trials unit now, that was for the first time concentrated the leadership of those trials within DC, where we had previously had partners across different areas of the country. And then, of course, GW partnered with Whitman Walker to create the position that I am fortunate enough to be in, which is the joint faculty member at GW and senior director of research at the Institute, which was a really exciting step in the partnership. And then most recently, we have taken that partnership to a new level through a grant that we were just recently awarded from the NIH Office of AIDS Research to develop or construct a collaborative research facility in Southeast DC in Ward 8 to conduct cutting edge HIV research, where both Whitman Walker and GW investigators will work side by side on various topics within the broad umbrella of HIV research. That'll be housed within Whitman Walker's brand new flagship facility that's being constructed in Congress Heights. And so we're really excited about that new opportunity to not only serve as partners, but also to work side by side with one another on the work that we are doing to end the HIV epidemic.
Oh, wow, wonderful, wonderful. And it's always good. You learn something new, folks, every day. I didn't know any of that. So that was literally a question of inquiry. 2 things that I'll get in. First, so for our students here who might be interested, who might have logged into this because they're like, I see Jonathon Rendina, I want to be him one day, or, them one day. Do you teach classes here? Exactly how do they interact with you? And then Kathy had a question in the chat that I'll try to get in after you answer that.
Sure. So I am a research professor, so most of my time is dedicated to research, but I will occasionally teach. I'll teach for the first time this coming spring semester a course on digital methods within epidemiology. So that's a graduate level public health course. And so that is the very first course that I'll be teaching at GW. This is also a great opportunity for me to advertise that we do have a research internship program at the Whitman Walker Institute that we just started. We are accepting our first round of applicants in January, and then we will take applicants twice a year annually. And so I am happy to share a link to be distributed, but it's whitmanwalkerimpact.org/institute/internships for folks that might be interested in exploring those opportunities for an applied research experience with us.
Sorry, I was on mute. Wonderful, wonderful. And I definitely would appreciate you sharing that link, because I do think our students are always hungry for opportunities to engage in this work. Kathy Thomas has the question: is that clinical trials network that you referred to in your answer the ACTG? I have no idea what that means, but hopefully you understand the question.
I do. The clinical trials unit oversees both the HPTN and the ACTG networks. So ACTG stands for AIDS Clinical Trials Group, and HPTN stands for the HIV Prevention Trials Network. So the DCCTU, which is jointly led by researchers at Whitman Walker and GW, oversees the Whitman Walker-based ACTG site and the GW-based HPTN site. So clinical trials are conducted at both GW and Whitman Walker. Right now, Whitman Walker does all of the treatment-focused protocols under ACTG, and GW does all of the prevention-focused protocols under HPTN.
Thank you for that. And if I could, I'd just like to take a step back now, almost because I think that there are many audiences that come to a World AIDS event, right? World AIDS Day event. Those that know about it and are like, this isn't getting enough attention, and those that don't know about it at all. And we're now reaching the sort of phase where, you know, most historical Holocaust sort of reach, where you still need to do some education, because the AIDS crisis is becoming as much history as it's becoming the lived experiences of many Americans. I'm going to just step back, and can you briefly, if you could, describe the history from your perspective of the AIDS crisis? How did it start? How did it evolve? And where are we today? You kind of walk us through where you would start to today as briefly as you can, if you can.
Sure, no problem. So it started in the early 1980s as an unnamed epidemic. In 1981, a story was published about a cluster of rare diseases that was being observed among gay and bisexual men in San Francisco and New York City. It was about a year later coined GRID, the gay-related immune deficiency, and it wasn't until 1982 that the term AIDS was coined. And HIV, the actual virus, the cause of the AIDS syndrome, was not identified until several years later. In 1985, the first HIV antibody test, which is one of the very common ways that folks get tested for HIV now, was discovered. So it took about 3 years before we discovered the virus that caused the disease, and another year before we had a test to actually determine whether folks were infected with that virus. So that's a very long timeline if you think about the COVID timeline and how quickly things accelerated with COVID. So that was about 4 years. The first treatment for HIV was not developed until the early 1990s. And the first combination treatment for HIV, which is the gold standard for ensuring the stoppage of HIV progression, was not developed until the mid-1990s. So it took almost 15 years before we started to see a decrease in deaths due to AIDS, when we finally developed treatments that could be used in combination to prevent the progression of HIV within folks. Fast forwarding into the present day, we now have a range of really highly effective prevention and treatment options. That includes combination therapies for the treatment of HIV that can be taken orally as well as injected. The regimens in the early days were very complex. People had to take a series of pills multiple times a day. Some of those pills needed to be taken with food. Some of them needed to be taken on an empty stomach. So it was a lot for people to manage. Most HIV treatments now can be taken in a single pill once a day. And then on the prevention side, we have a lot of options that have moved very far beyond use a condom every time, which include pre-exposure prophylaxis, which is a pill that can be taken every day or on a specific schedule or through an injection that can be given every other month now, which just recently became FDA approved in the past year, as well as PEP, which is post-exposure prophylaxis, which is a very similar concept, but if someone is exposed to HIV, has a high-risk exposure to HIV, they can take PEP every day for 28 days following that exposure to also significantly reduce the likelihood of an HIV infection resulting from that exposure.
No, thank you, thank you, thank you for that. I want to stick with this line of questioning for 1 second. I know one of our more illustrious alumni, Dr. Miranda Ward, has a question in the chat, and I'm going to try to rope that in 1 second. But I want to stick with this line and just say, you know, of course, we shouldn't be generalizing. We're not going to generalize in this conversation. If you've talked to one person living with HIV, you've talked to one person living with HIV. You can't generalize. But with that said, from your expert point of view, how would you describe the experience of someone living with HIV today in 2022? We just came through a worldwide pandemic where someone living with HIV probably interacted with, COVID. We've had a resurgence, then a non-resurgence, and a resurgence of monkeypox. Compared to when it was a plague in the 80s, had things gotten better? Have things gotten worse? How would you sort of answer that question?
I think that the easiest way to answer that question is to say that on average, things have gotten better. I think for a person who has the means to access treatment, that the treatment is very highly effective. Folks can even miss a dose or two a week and most likely remain with a suppressed viral load. So viral load is the amount of HIV that's circulating within the bloodstream and is correlated with the progression of HIV. And so as folks' viral load increases, their health decreases. They get things like a lower CD4 count, as well as other AIDS-related complications. And so the treatments these days are highly effective and a lot less burdensome on folks. And I would say that stigma has decreased in some ways and has been very stubborn and stayed around in a lot of other ways. And so I think it really depends who you are, whereas the experience of HIV was pretty much universally negative for the first 2 decades, and the life expectancy was not good. Folks who are diagnosed with HIV today can have an average life expectancy that is the same as someone who has not been diagnosed with HIV, but that is a privilege. And so, as we know, with all health issues, privilege is a huge issue. And so I think for folks that have the means and the access, things have definitely gotten better. But there are still a lot of folks that do not have that level of healthcare access, trust in a provider who they feel confident disclosing their HIV status, or means to get into care.
I got some pushback. I get pushback on most things I do here about, why as an education school doing a World AIDS Day event, if someone posed that question to you, maybe not as part of GW, but just, in general, why is it important, since we have gotten so much better at both preventing the virus and treating the virus, why is it so important to commemorate something like World AIDS Day every December 1st still in 2022? What would be your answer?
I would say that for all the progress we've made, we still have a very long way to go. Back in the early phase of the epidemic, folks thought we would have a vaccine for HIV within 2 years. We obviously have now been living with HIV for more than 4 decades and do not have an effective vaccine. We also do not have an effective cure, although treatment is so highly effective that in some cases it can cause what is referred to as a functional cure, which is that HIV is so suppressed that it's no longer causing health complications, that HIV will remit as soon as treatment is stopped. And so I think that there is still a lot of need to talk about HIV. I think the other really important thing that HIV highlights and that COVID also really pointed to is health inequities. And so HIV is an unfortunate example of the ways in which different communities are treated differently by the systems that we have, particularly here in the United States, geared towards health. And so I think we will not see an end to the HIV epidemic until we address some of those systems, and the educational system certainly is an important partner in that process.
I want to turn to the question from Dr. Miranda Ward, who is a faculty member in our med school, as well as, like I said, an illustrious graduate of the Graduate School for Education and Human Development. And she starts right where you just left off. She wants to know, in what ways could our COVID pandemic response learn, if any, from how we responded to the HIV pandemic? Any thoughts on that?
Sorry, can you repeat the question? I was trying to read it in the chat and I don't know that I read the right one.
Yeah, no. In what ways could our COVID pandemic response learn from how we address the HIV pandemic? Any thoughts on that?
I think we see similar problems in the response to both epidemics. For example, we saw that Black and Brown folks were significantly less likely to gain access to vaccines for COVID early on in the pandemic. And I think that we have seen very similar things in the HIV epidemic. Although we have amazing technologies now to prevent and treat HIV, not everybody has the same level of access to those, particularly as they first come out, right? So access tends to lag for some communities, and those include LGBT communities and communities of color, and particularly those that are at the intersection of those identities. We see a lot of issues in terms of HIV-related access among trans communities of color and trans women of color. And so I think that that the HIV epidemic and the COVID epidemic can learn a lot from one another, but basically because both of them have been victim to the same mistakes.
And bringing it back home to DC, both, beyond the river and, above the river, Dr. Ward wants to know, are you a member of DC CFAR? You are. It was in the bio, so I'll just answer that for you. But I think her core question is a little deeper. In what ways do you work with the DC community beyond Whitman Walker Health? Do you engage in community engaged research with DC residents involved in helping to design the research, analyze, or help determine the data, the story? Are you working with residents or members of the DC community in your research now?
Yeah, that's a great question. So we do a lot to engage in Whitman Walker Institute to engage both patients of Whitman Walker Health and non-patients of Whitman Walker Health in our research. So we do a lot of community-based recruitment for our research studies. We partner with the community health team within Whitman Walker Health, which goes out into the community to various events to do things like HIV testing, and they went out and did COVID testing. So we do a lot of that, and we are working to do better with that. The Institute is relatively new, and we are in the process right now of developing a community engagement group that will bring members of the DC community in to help guide the research, education, and policy work of the Institute. That will be an expansion of what we've traditionally done within research, which is to have a community advisory board. So we do have a research community advisory board that meets once a month to guide us on various research topics of interest, to help us understand what we're seeing in some of our existing research studies, as well as plan for new research studies. But we are definitely working to increase our engagement of communities within that, and to also expand beyond just the research work, to also think about what are priorities for community in terms of policy, advocacy, and education.
Okay, fair enough. Folks, keep the questions coming. We are recording this segment. As soon as we get to right around the 12:50 block, we will stop the recording and you can go no holds barred. But just know any questions you inject in here will be part of the recording. But I like them. Please do keep them coming. I want to return to the structure of education. You mentioned it in one of your answers a little bit, but I want to really core in on education. And I'm really interested in the connection between education and the prevention of the spread of the virus, both among youth, LGBT youth, heterosexual youth, amongst adults, both within the minoritized and the majority community, communities that folks typically associate with the LGBT community, and communities that folks don't think about when they think about the LGBT community. How have educators contributed to the prevention of the spread of the virus? And maybe as important to that question, what aren't we doing? What are things that we might be doing that are making your job harder right now as far as educators in connection to the spread of the virus? Any thoughts on that?
Yeah, so I think certainly transparent sexual health education is a key component of the HIV response, and in terms of just allowing folks to live healthy and happy sex lives in general. There has historically been a lot of infringement of beliefs on the education that folks receive with regard to sexual health. And so I think, that it's totally fine for people to have their values with regard to sexual behavior, but that everyone should have equal access to accurate information about sexual health options. And so I think that starts in schools at early ages, because folks are at risk for HIV and all other sexually transmitted infections from the moment that they begin engaging in sex. And that typically happens on average for most people during high school. And so I think educators play an important role as frontline folks that are there to provide accurate information to everyone.
No. So you mentioned sex education, and here at GSEHD, we pride ourselves on educating really from the floor up all the way, right? We talk through, it's P through the end of your educational journey, which, if you're privileged and blessed enough, doesn't, end until, you leave this earth. But let's talk about sex education, both on a preschool or a, early introductory level. And we might, throw in things there like Florida's Don't Say Gay bill and how that affects it on a adolescent level, but even at a college level, right? There is very few sexual education mandated courses, even at a school here at GW. If you had to identify, let's say one or three, there might be 20, there might be 100 things that are lacking in the sex education curriculum in America today. Let's limit this conversation, even though it's World AIDS Day, to America, just so we can sort of cognize the problem, that if corrected would make your work easier. What would those 1 to 3 things be? If you gave you, Jonathon, a magic wand and, working with GSEHD, you were able to correct 1, 2, 3 things in sex education curriculum through the spectrum, K through 12, post-secondary education, adult education, what would those 1 or 2 or 3 things be? And how would that make your work easier?
Yeah, I mean, I think, comprehensive sex education would definitely be one of them. And I agree with you, that should be developmentally staged and occur across the lifespan. Folks have evolving sexual health needs and questions and concerns. And so I think, ideally that would start as early as possible on issues like anatomy, and then move on to some of the other important topics like prevention techniques. It In 2022, I would say that the vast majority of people are still not aware of PEP, which is post-exposure prophylaxis, which is a life-saving option for folks that have been exposed. It's more common to understand occupational post-exposure prophylaxis, which can be taken, for example, by a medical professional if they have a needle stick. But there's also non-occupational post-exposure prophylaxis, which can be given at a place like Whitman Walker, as well as many other medical and sexual health clinics, same day. As soon as you have an experience where you believe that you may have been put at risk for HIV, you can go and you can receive a prescription for 28 days of medication to prevent HIV. And so I think knowing that those options exist can not only help you in your own life, but may make you a resource for someone else who may not be aware of those options if something were to happen to them. Because the window for PEP, for example, lasts really only for 72 hours. Once you get past 72 hours after exposure, the effectiveness of PEP goes down significantly. And so it's important for people to be made aware of that in advance, so that if those occurrences do happen, they're able to take the steps that they need to protect their own health. I would say that the other biggest challenge that we have, and this has been something that I've been grappling with as a psychologist trained to work with people, I think actually that we are now seeing in the later days of the HIV epidemic, that the issue, like I said before, is with systems and with structures, that our healthcare system is not adequately designed to address the needs of a diverse population, that people do not have equitable access to care that is culturally competent and able to treat them in the ways that they need to be treated. Trans people are one example of that. You mentioned the Don't Say Gay bill, but there's also been a lot of legislation that has been anti-trans over the past several years. That all of those things limit not only well-being, but access to culturally competent care. And so I think the other thing that we really need to be focusing on in health education is that it's not all about individuals. It's not all about individual behavior or about individual risk factors. Those are certainly components, but we don't do enough to educate people about the ways in which our legal system and our criminal justice system and the health system obviously also impact health for folks. And so I think a greater eye towards the upper levels in a multi-level understanding of health is important and is not done nearly enough. I think, there has also been a move towards education that does not acknowledge the importance of feminist history and Black history. And so I think, we are just seeing a real pushback against these things that I think are incredibly important to a comprehensive understanding of health.
So, one of the things you started talking about was your own work in social psychology. And I'm often, thinking, even though right now I probably will be classified as highly educated, about the lack of education that I had growing up as a youth, right? I learned even as a young LGBT American about HIV/AIDS through a show called Noah's Ark, right? There was no formal education. And, I went to New York City public schools. I went to some of the best New York City public schools. I went to an HBCU, and now I have, maybe, several academic degrees, and still in engaging with the youth in New York City and engaging with the youth in DC, there's still this blockage of stigma, right? A stigma around people's personal choices, a stigma that is preventing people from getting that adequate education they should get, and therefore helping the spread rather than a prevention of the spread of the virus. You happen to be an expert on stigma, several published articles on stigma. Could you just talk a little bit before we go to the general Q&A about the connection between stigma and how reducing some of that stigma would help the prevention of the virus, and what initiatives educators should be undertaken in the classroom, even if they're not sex educators, to reduce that stigma?
Sure. So just in terms of a working definition, stigma includes experiences like discrimination as well as stereotypes when the characteristics of a behavior or of a person are used to classify or characterize folks in a negative way. And so I think one thing that's really difficult to grapple with, but really important to acknowledge, is the ways in which public health has actually created quite a bit of this stigma in messaging around use a condom every time. For example, we created a sense that there was only one right way or appropriate way to be, and we formed a type of stigma. We created a stigma against people who, for a variety of reasons, may not have been willing or able to use condoms. And so I think actually HIV stigma inadvertently became the result in large part of public health campaigns that had the intention of saving lives and reducing HIV infections, but intention and impact are not always the same thing. And I think a large result of public health campaigns for 4 decades around HIV prevention came to be the stigma against HIV. So for example, one very common form of HIV stigma is that people without HIV will not have sex with people who have HIV. And this was actually encouraged for decades by public health officials. It was known as serosorting, and it was considered to be an HIV prevention technique that you would not have sex with people who were known to be living with HIV. What we now know is that folks who are living with HIV are on average on effective treatment. They and are likely to be undetectable in terms of their viral load, and that actually a person who is living with HIV who is undetectable cannot transmit the HIV virus. And so that is knowledge that only just came out and started being endorsed by public health agencies within the past 5 years. In 2017, the undetectable equals untransmittable movement was started to be endorsed by public health agencies in the United States. That was huge, but that's also 35 years too late. We have built up a notion among most communities now that people living with HIV are dangerous, and certainly when it comes to sex, we should not have sex with them. And in fact, what we now know is that the vast majority of new HIV infections result from sex without a condom with someone who believed they were HIV negative, but had actually recently gotten HIV. And so the idea that we should use someone's HIV status as a means of deciding who to have sex with is actually a failed public health idea, because it actually increased risk to HIV, because we were telling people that it's safer to have some sex with someone who's HIV negative, when in fact, some proportion of those folks actually were living with HIV and didn't know about it. And having sex with someone who is unaware of their HIV infection means that they're also not on treatment for HIV and are not likely to have an undetectable viral load, which means that there's a much higher risk of transmission in that sexual situation.
Wow, that was a lot of knowledge there. I'm glad we're recording this. I want to give a brief personal privilege and say shout out to the Center for HIV and Law Policy in New York City, which was my first internship when I was in law school. And they're holding today a rally against HIV criminalization. And I want to add my voice to the call for the end to HIV criminalization, based exactly on what Jonathon just said, right? HIV criminalization is a criminalization basically of people living with HIV for no reason but the fact that they're living with HIV. And this happens both in our criminal injustice systems around America and on college campuses, as quiet as it's kept. And I think that, we need to start using that term and fighting against all oppressions, including the oppression that comes from HIV criminalization. I've got one more question for you, and then we're going to open it up to the second segment of this, which is just a no holds barred sort of Q&A with the audience. We have a lot of expertise in here, Dr. Miranda Ward, Dean Lionel Howard. We have the director of GW's LGBT Resource Center, AJ King, in here, Dr. Amanda Castle. So I'm really looking forward to the audience Q&A. Here's this last question, and it's a shot at academia. And I understand that. I'm sitting in the castle, I'm sitting on the plant station, but I'm going to take the shot anyway. Academia has done a lot to help, but also has done a lot to hurt. In your opinion, as someone who sits in a community engaged space, but shares an appointment in institution, the George Washington University, named after a slave owner, we have to call it out for what it is. How have there been communities that academia have left out? I'm thinking specifically now about my friends in the ballroom community here in DC, in Philadelphia, in New York City. I'm thinking about undocumented immigrants, as I was once an undocumented immigrant who says, yeah, I might want to go get this monkeypox vaccine. I might want to go get this service at Whitman Walker, but I'm not sure that my status is going to be exposed. I'm thinking maybe mostly now of our transgender Americans and the violence and the intersectional violence that's reigned at them. Has academia's outreach efforts around HIV and AIDS to these particular communities been poor? Have we left them out? And if so, based on your expertise, how do we start to build those bridges if they aren't already there? Feel free to push back against the question, but it is what it is.
Yeah, no, I mean, I definitely will not push back against the question. I have a lot of my own concerns about academia. I think one of the most fundamental things is a lack of acknowledgement that community knows best. Within the HIV epidemic, for example, there were people in community who understood that folks that were on effective HIV treatment were not a high-risk partner for transmitting HIV well before we demonstrated that scientifically. And so I think there has been a lack of acknowledgement of community knows best. And I think that that results from the lack of diversity among folks in academia who represent those communities. And I think that that is the result of many things, including the tenure system that is highly individually focused and does not always appeal to people who are interested in conducting team-based, community-engaged research. And so we lose out on having those folks in academia conducting research in those spaces. I'm definitely glad to have found Whitman Walker and to be able to work with folks who are not interested in academia, but who are interested in leading research on health. And so we do have some of our own research scientists working directly at Whitman Walker who are not affiliated with any academic institution. And I'm definitely seeing among younger generations of folks graduating with doctoral degrees that is a growing interest, is to step outside of academia and to think about ways of doing community engaged research in other settings. And I think that that's really exciting. And I think that that's one of the biggest privileges of my role, is to try to build the infrastructure for that type of pathway to exist for people. And so I definitely think that academia has left people out. I think that that has been both intentional and unintentional. Academia is an exclusive system by design. Tenure by design is you either get included or excluded. It's an explicit process of decision making around that. And so I think that for sure there are a lot of limitations of academic research, and I'm just glad to see that we're starting to recognize that there are other valid options for people to pursue, because I think even just a decade ago, the idea that you would get a PhD and then go work in a community-based setting and not in an academic setting was almost impossible to imagine. It would be almost impossible to get a grant in that kind of setting. And we're starting to finally see that shift, but there's a lot of bias still within grant reviewers, for example, and funding agencies that I think there's still a lot of work to address.